I would like to thank you for joining us for first 2022 Tizard Seminar, and I would like to welcome Professor John Taylor from Tyne NHS Foundation Trust, who will be discussing with us today the Transforming Care Programme and the proposed mental health legislation changes for people with learning disabilities. We will be taking questions towards the end of your presentation. Can I please ask from everyone to mute, and over to you, John.
Thanks very much, Vivi. I hope everybody can hear me okay. Just give me a thumbs up if you can. Great. And can everybody see the front slide? Great, thank you. Okay. Yeah, I'm John Taylor. I'm based up in Newcastle in the northeast of England, working out of Northumbria University in Newcastle, and it's a snappy title for a trust: Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust, which, for those of you who are interested in these things, goes from Whitehaven across in the Lake District, the west coast, across to right up to Berwick in the north on the Scottish border, and down to more or less Durham in the south. So it's a pretty big geographical spread. But I'm going to be talking to you today about Mental Health Act reforms. This was the starting point, I think, when Glyn asked me to do a talk. But it seemed to me when we're thinking about Mental Health Act reforms, we're kind of forced to think about those reforms in the context of the Transforming Care Programme for people with learning disabilities and autism. And when I started to think about these reforms in that context, it led me to look at the interface of those programs with positive behavioural support, and again some work I've been doing with Peter Baker and others in thinking about the impact of PBS on services for people with learning disabilities in particular. So I'm going to kind of go on a fairly sort of quick gallop through some of this stuff, because we haven't got that much time. I'm told I probably need to shut up around about 22:45 and allow for discussion. But the starting point for my thinking is in this very short paper, comment piece, which was published in the Lancet Psychiatry at the back end of last year, really beginning to think about removing people with intellectual disabilities and autism from the England and Wales Mental Health Act. I was a member of the independent review panel on the Mental Health Act reforms, and there were a number of discussions went on in that forum, which don't seem to, the outcome of which doesn't seem to really chime with what's being proposed in the white paper. But to just remind people, refresh memories, under the current Mental Health Act, the 1983 Mental Health Act, which was amended in 2007 by the Mental Health Act 2007, people with learning disabilities can be detained under the Act, but that's qualified. So detention is required only if it's for the person's health and safety or the protection of others. And there's what's called the learning disability qualification. People can only be detained under the Act on the basis of learning disability if they're demonstrating what is described as abnormally aggressive or seriously irresponsible conduct. Without those qualifiers, people with learning disabilities can't be detained under the Act. Now, what's being proposed in the reforms to the Mental Health Act, and these were published in the white paper in January, well, 2021, so that's a year ago now. What's being proposed is that learning disability and autism will no longer be considered mental disorders warranting detention for treatment under the Mental Health Act, so Section 3, treatment orders. People with learning disability or autism will only be able to be detained under Section 3, so these are civil sections of the Mental Health Act for treatment, if they have a mental health condition in addition to learning disability and autism. And only if that mental health condition, other than learning disability or autism, is driving abnormally aggressive behaviour, that should be, or seriously irresponsible conduct, which results in substantial risk of significant harm to self or others. But somewhat strangely, in my view, whilst it's proposed that people with learning disabilities and autism won't be subject to detention under the civil sections of the Mental Health Act, Section 3, they can be considered for detention under criminal sections of the Mental Health Act. So that means that if people have committed an offence and they go to court and they're convicted of those offences, the courts will still be able to issue a hospital order, so people detained under the Mental Health Act for treatment under those criminal sections. Now, what's the rationale for these proposed changes? Well, it's unclear to me. Excuse me. And if we go back and look at No Voice Unheard, No Right Ignored, so this was a Department of Health consultation in 2015 relating to people with learning disabilities. It set out a number of options for amending the Mental Health Act, including removing people with learning disabilities from the orbit of the Mental Health Act. But interestingly, the Department of Health's response to its own consultation stated that it's clear there is no clear mandate for changing existing legislation in any particular direction. And respondents to the consultation highlighted the risks of potential unintended consequences of the options presented, including removing people with learning disabilities from the Act. And the Department of Health concluded, we are convinced that these proposals will require much more exploratory work before moving on to any form of legislative change. So that's 2015. Now, it's not clear to me where this exploratory work went on, except there was, as I mentioned earlier, the independent review of the Mental Health Act, which published its findings in 2018, called Modernizing the Mental Health Act. And just to review what the independent review concluded, it considered carefully the removal of people with learning disabilities from the Mental Health Act, and it did indeed identify cases where the Act had been used inappropriately with people with learning disabilities, cases where there'd been substandard treatment, people detained in poor environments, and of course with prolonged overlong admissions. But the independent review also found evidence of the Act being used in a principled and positive way that aided the recovery of people with learning disabilities. And it said, this illustrates that the Act can and does work for people with learning disability, autism, or both. And it concluded that the issues arising from taking people with learning disabilities and autism out of the Act are significant and could cause further harm. I think that's pretty clear. Now, what about those unintended consequences? Well, I think to get a glimpse of what those might be, we need to look to the only common law jurisdiction that has gone down this avenue so far, and that's New Zealand. Now, New Zealand removed people with learning disabilities from its mental health legislation in 1992. And to cut a long story short, this seems to have resulted in people with learning disabilities and behaviours that were a risk of harm to others being sent to prison. And because of that gap in the legislation, new legislation had to be created. So they implemented the Intellectual Disability Compulsory Care and Rehabilitation Act in 2003. And the effect of those changes actually was net widening, with larger rather than lower numbers of people with learning disabilities becoming subject to compulsory care in detention. And a further effect of those changes was an erosion of clinical expertise of mental health professionals trained to deal with people with learning disabilities and complex needs. And there's a nice paper by Jane McCarthy and her colleague Duff in 2019 that describes those effects in more detail. So it's not clear at all where the proposals in the white paper emanate, what the impetus is, because the Department of Health's own previous consultation concluded there was no real evidence to support those changes, and the independent review was concerned that it would result in unintended consequences and increased harms. So I think we need to look further afield to get some sense of perhaps where these proposals are coming from. And I think we need to consider the Transform Care programme, which people will recall started following the BBC Panorama expose in 2011, where systematic abuse of people with learning disabilities was found in the Winterbourne View Hospital in Bristol. Call it a hospital. My understanding is it was a pretty small unit run by Castlebeck Care, an independent provider. And then we had similar scandals uncovered at Walton Hall, 2019, and Glyn led an inquiry into and provided a report on that. More recently, the Corston Park scandal last year in Norfolk. Note all three in the independent sector. It's not to say that things are not which shouldn't happen aren't going on in NHS hospitals. Of course they are, but these are where the systematic abuses were uncovered and have been exposed to date. But following the Winterbourne View, there was a concordat produced, which was to address these issues and to look at reducing the numbers of people with learning disabilities in inpatient services. But by 2015, things weren't really progressing, and we had reports such as the MenCap report in 2015, Winterbourne View, the scandal continues, which concluded nothing has changed since 2011 and the Panorama expose. And then what happens is, and perhaps this is where we begin to get a sense of where did some of these policy initiatives come from. Simon Stevens, the NHS, and he was Simon Stevens then, he became Sir Simon and now Lord Stevens, under pressure in a parliamentary public accounts committee in February 2015, and it's all in Hansard if you want to look at it. I can point you to it if you want to look at it in more detail. Committed to a 2-year learning disability closure programme. But there was no sense of what analysis of need or what the alternatives were to replace these beds. This seemed to be, as far as I can see, policy on the hoof, frankly. But what Simon Stevens did say in that hearing was we cannot have a situation where we simply reduce the NHS provision and instead it just flows into third-party providers that expand on the back of it. Please keep that in mind. So on the back of Simon Stevens' policy initiative announced in the Public Accounts Committee, we then get, later on in 2015, Building the Right Support, that people will be familiar with, a national plan to develop community services and close inpatient facilities for people with LD and autism who display behaviour that challenges. And in short, through the Transforming Care plan, the idea of building the right support was, well, currently there are 2,600 patients, this is at the time, in people with 2,600 learning disability inpatient beds. That number is to be reduced by 35 to 50% within 3 years, so that's by 2019, and this is to be a starting point. And the money saved is to be reinvested in community services. Okay, so let's look at the numbers. So this is assuring transformation data. This is the Transforming Care Programme's favoured data set produced by NHS Digital. And what we have here is in March 2015, the numbers of people with learning disability in inpatient beds, just under 2,400. This is March 2016 and March 2019, when the Transforming Care Programme was meant to have concluded and reduced beds by 35 to 50%. And as you can see, there's only a small reduction to 2,260 people with learning disabilities in those beds. So at the end of March 2019, when Transforming Care was meant to have done its job, there were 135 fewer people with learning disabilities in hospital than in March 2015. So a 5.6 reduction. So that's a bit of a shortfall, isn't it? But then the Building Rights Support plan was superseded by the NHS long-term plan in 2019, which pledged to reduce the 2015 bed numbers by 50%, but this time with an extended time frame of 2023-24. Okay, so we're now in. Okay, so this is where we are, or we were in March 2021. So this is now Building the Right Support. It's taken over from, the 5-year forward plan has taken over, long-term plan has taken over from Building the Right Support. And at the end of March 2021, there were 2,035 people with learning disabilities in inpatient beds. So 2 years in to the long-term plan, there's a reduction of 15% over the 2015 figures. So they don't seem to be really getting close to the 50% at the moment. And the situation is even worse if you consider the other NHS digital data set, which counts the number of people with learning disabilities in inpatient beds. Now, this is service provider returns as opposed to the assuring transformation data, which Transforming Care prefers, which is commissioner returns. But the providers are telling us that in fact there are 3,310 people, or there were 3,310 people with learning disability in hospital at the end of March 2021. So the numbers really don't add up, I think. And I think we can see why, because to reduce the number of people with learning disabilities and autism in inpatient beds, you need to reduce the numbers of admissions and you need to increase the numbers of discharges. Seems to make sense. And this is a little table that's published in the Lancet psychiatry paper, which I pointed you towards at the beginning of the presentation, based on the assuring transformation data published by NHS Digital. You can see that when we actually look at discharge to the community, look at admissions, the number of admissions in March 2015 were 50, 2019 at the end of the programme, and March 2021, the number of admissions had increased, in fact. And whilst we don't have discharges to the community for 2015, we can see that between 2019 and 2021, discharges to the community during those months really haven't changed very much at all. So the 2015 Building the Right Support plan told us, didn't it, that bed closures would release tens of millions of pounds, which would be invested in community-based services to support, to prevent hospital admissions. But in 2017, the National Audit Office raised concerns about these targets due to a lack of community infrastructure and an inability to close beds. And it was told us then, back in 2017, that money is not yet being released from hospitals quickly enough to help to pay for extra community support. And it seems that things haven't improved much in the meantime, because the 2021 Parliamentary Health and Social Care Committee report says, on people with learning disability and autism, said the current system of community support in England is broken, systematically failing, or otherwise inadequate. Now, I'm not going to dwell on this, but I think one of the issues is that we were told that the Transforming Care programme wouldn't result in increased numbers of people going into independent sector for-profit provision. But a report published by Chris Hatton and colleagues at Lancaster University in 2017 called A Trade in People kind of suggests that that isn't the case, that the proportion of people with learning disability in independent sector beds was growing, and the market was increasing, and really this approach was turning people with learning disabilities into commodities and liabilities, and inpatient rates were being influenced by development of services in areas where house prices were lower. And this was happening despite evidence that the experience of assault and restraint is increased in independent sector provision. So just to remind you what Simon Stevens said in the Public Accounts Committee about independent sector provision, and just illustrate this problem with in relation to the case I'm currently working with clinically as a responsible clinician of a woman with a learning disability who has been identified as needing secure provision since February last year because of the level of risk she presents to self and others. Because of that risk, she's being looked after in an acute psychiatric intensive care unit bed, actually in seclusion, continuous seclusion. And we've learned that currently there are only 4 providers of secure beds for women with learning disabilities across the whole of England. The majority of those are being provided in independent sector services, all of which are currently closed, being closed by the CQC. So we have a situation where a woman with complex needs who has been clearly identified as requiring specialist care and treatment in specialist services isn't able to access those services because most of them are in independent sector provision and most of them are closed because of quality concerns. So if people want to read a bit more about transforming care, then there's a paper here in 2019 in the British Journal of Psychiatry Bulletin outlining some of the concerns we were having then, and then again more recently towards the end September 2021 another paper I did for Lancet Psychiatry, short paper, taking stock of where we were last year. So what's in the link up here is that in the Reforming the Mental Health Act white paper, it's clearly indicated that one important motivation for the proposal to remove people with learning disabilities and autism from its scope is the government's commitment to reducing the reliance on specialist inpatient services for people with learning disability and autism, and to develop community alternatives. So my take on this, shared by others, I think, is that following the failure, the clear failure of the Transforming Care programme, rather than address the absence of investment in community services, or to reconsider the basis and the rationale of the programme and the reasons it's failed, the government is planning to legislate its way out of the problem using Mental Health Act reforms, despite the advice of the independent review and the experience in New Zealand. But I think there's another dimension to this confluence of issues and problems. And it's to do with the model of care for people with learning disabilities and complex, challenging behaviours, including offending behaviour or behaviour that is at risk of offending. Just to remind you, detention under the Mental Health Act currently, on the basis of having a learning disability, requires a person to be demonstrating abnormally aggressive behaviour and/or seriously irresponsible conduct. And I'm emphasising abnormally aggressive behaviour because every challenging behaviour survey published that I've ever been able to find always has aggression as the most frequent challenging behaviour that causes community placement breakdown, whether that's in the family or supported care, and results in admission to institutional care. Always does, and I'd be amazed if people can find me any piece of research that doesn't show that. And this is just one example of some work I did with colleagues Greg O'Brien and Tony Holland and Bill Lindsay and a host of others a few years ago, looking at pathways into services. And we looked at people referred into services because of offending or offending type behaviour over a 1-year period in 3 regions, in two in England, 1 in Scotland. And this is a sort of common result you find. Physical aggression, verbal aggression is high on the list, along with sexually inappropriate or harmful sexual behaviour following on its coattails. Okay. And this is not just sort of one-off problems that people are being referred for. Nearly 80% of the people referred have presented with the same index offending type behaviour previously. 40% for multiple incidents, that's 5 or more of the index behaviour, and there've been police involvement in over a third of cases, and nearly 40% had resulted in previous police charges. So this is not insignificant or incidental behaviour. But most of those people are being referred to mainstream community and mainstream inpatient learning disability services. And most practitioners, with good reason, in those services adopt a values-based, person-centred approach to their work, based on the principles of normalisation, social role valorisation. And I think for people with learning disability who display challenging behaviour, particularly aggressive challenging behaviour, that approach to working with people and those problems incorporated into positive behavioural support plans. And to that extent, PBS has become central to Department of Health policies, including transforming care and workforce development. And subsequently, very significant funding has flowed into PBS training programs in the NHS in England at least. But when we look at the Challenging Behaviour and Learning Disability Guideline published by NICE in 2015, which Glyn chaired, as I recall, one of the review questions concerned behaviour that challenges and psychosocial interventions aimed at reducing and managing behaviour that challenges. And whilst behaviour support plans were recommended, in relation to PBS, the reviews did not find any evidence on the effectiveness of PBS. And I know that's unpalatable to a lot of people, but that was the finding, the outcome of that NICE review and guideline in 2015. And I know this is unpalatable to lots of people too, and people have lots of concerns about the Aseotis cluster randomized controlled trial, but nonetheless, it is the only RCT and the biggest one that's been completed to date. Qualified staff in 23 community teams, 246 service users with behaviour problems, randomly allocated to treatment as usual or treatment as usual plus PBS, no improvements. on challenging behaviour at 6 and 12 months follow-up. And then more recently, Karen McKenzie and colleagues up here in the Northeast, a controlled trial of PBS skills training involving 299 staff in social care services, allocated randomly to accredited BPS or no training programs, working with 207 service users with behaviour problems, no improvements on challenging behaviour post-intervention at three months follow-up. And then more recently, Peter Baker, Magali Banu, Jess Collins, and International Journal PBS, systematic review of PBS in forensic settings, papers published between 2005-2019 found just 11 studies concerning PBS interventions, 6 skills training studies, 5 direct PBS interventions. Just 3 of those 11 studies, with an N of 42 in total, included challenging behaviour as a dependent variable. All 3 of those studies reported positive outcomes. That's good. But 2 of those studies were single case studies, and those single case studies were the only PBS studies in that review that involved participants with learning disabilities. And Magali and Peter Langdon, in a chapter for Health Education England commissioned Community Forensic LD Resource book published last year, couldn't find any studies on the effectiveness of PBS for people with learning disabilities and forensic needs in community settings. So really, we have a model of care based on PBS that really doesn't have an evidence base as such to support the investment in people with learning disabilities who display seriously aggressive and offending type behaviour. We have in effect 2 case studies. And again, my invited commentary on this and more detail on the background is in that special issue of International Journal Positive Behaviour Support on PBS and forensic settings last year. But we do, and that's important because in secure services, and this is the National Service Specification, core objectives are to reduce harm to others, and risk to others is mentioned 86 times in 41 pages. And services must provide, according to that service specification, evidence-based specialist assessment, care and treatment, including reduction and or management of risk through provision of specialist offence-related treatment programs that address offending and risk behaviours. I'm not sure we're doing that. And the risk, the model of choice in relation to addressing criminogenic need in relation to offence-related behaviours is the risk need responsivity model. It's the established model demonstrating most effective outcomes. It does focus on criminogenic needs, primarily disocial attitudes and cognitions and skills training, using offence-specific interventions incorporating cognitive behavioural interventions, which might in themselves incorporate ABA or PBS based approaches. And we do have a bit of evidence and guidance that these interventions should be used, and in the same NICE guideline 11 on challenging behavioural disabilities, for instance, in relation to anger-related problems, we should be considering use of CBT-based interventions delivered individually and in groups. But the fact is, we're not. And this is from a paper that Bill Lindsay, myself, along with others, published in JIDR back in 2012. So it was a part of the pathway study, and the red blocks here show that these are the people accepted into services in community, forensic community, low, medium secure and high secure settings. And in relation to violent index offences, these are the yellow and green blocks are the people receiving offence-focused interventions at 12 and then 24 months following their admission into those services. So you can see that very few people are accepted into these various service settings 12 and 24 months on are actually receiving evidence-based interventions for their index behaviours. And if you substitute harmful sexual behaviour or fire-setting behaviour, substitute those behaviours into those slides, you get exactly the same results. So this is an issue that they have already experienced and gone through in New Zealand. Am I a therapist, social educator and trainer, or am I a jailer? So in New Zealand, following Mental Health Act reforms, practitioners using normalization principles became responsible for managing people with learning disability with very significant forensic risk needs. And that created a huge tension and difficulties in the workforce, and that approach didn't work. And there's a really interesting paper by Preble et al. 2013 with the title, The Care Manager's Dilemma, Balancing Human Rights with Risk Management under this is the New Zealand Act. And I think that tension can be seen in the sense that if we look at the Building the Right Support National Plan 2015, this is the front cover. So this is kind of indicating the population, the client group that I guess we're meant to be dealing with. Now these are pictures which are in the public domain. This is in Newcastle Evening Chronicle. This is you know, one of the people referred into our services because of making fake bomb hoax calls. And this is the front cover of the Building Right Support Service model, suggesting this is the kind of client group we're working with. Again, from the Evening Chronicle in Newcastle. It's one of the people who referred to our services for committing sexual offences on the metro underground system in Newcastle. I think we can see there's a bit of a category error going on here in terms of the populations that we're dealing with, and probably explains why the Transforming Care programme has failed so miserably to move people out of hospital, because we're not dealing with people like this, we're dealing with people like this who present very different problems and have very different needs, in my view. So what happened in New Zealand because of that tension, there had to be a wholesale review of the model of care for service users under the new Act, and a new skills framework was developed based on risk, need, responsivity and offence-focused interventions that had to be then developed and implemented. So they had to reinvent the wheel in effect. So I'm finishing in a moment. So summary, the UK government's proposing to remove people with learning disability and autism from the scope of the Mental Health Act in England and Wales. The rationale for those changes are not clear, and they seem to be counter to the commissioned independent advice and evidence from elsewhere, primarily New Zealand. In part, they appear to be a response to the failure of the Transforming Care programme, the basis for which is also unclear. And the proposed reforms are likely to result in a lack of care and treatment in the community, an increase in the use of the criminal justice system, possibly a need for duplicate legislation, and I think ultimately a diminution in the rights and protections for people with these conditions. I think another serious consequence of the proposed changes is a loss of specialist professional skills and knowledge to meet the needs of people with learning disabilities and complex behaviours, including offending histories, and dependence on practitioners who don't have the necessary training and expertise in the evidence-based approaches that are required. So my conclusions are that the government should review these proposals and think again, taking into account the conclusions of the independent review and the New Zealand experience. I think the NHS England should review its transforming care programme with a view to reforming services based on a proper analysis of the needs of people with learning disabilities and complex presentations, including a sensible look at actually how many beds are needed and where, rather than the rhetoric of closing all beds. Because we can, only they can't. And NHS England, Health Education England should probably stop investing in superficially attractive but unproven interventions and divert resources into evidence-based interventions which are delivered by skilled therapists. That can lead to better outcomes and I would say better lives for people with learning disability and complex and forensic needs. And I'll stop there.
Thank you, John. Thank you very much for your presentation. That was really informative.
Should I stop sharing?
Yes, please, if that's okay. And we can then start taking some questions. There's a lot of comments on the side, so I'm going to let you perhaps read those in your own time, so we can go on with discussions, live discussions now, if that's okay.
I'm trying to figure out how to stop sharing. Can't do it.
So it should be at the right top corner next to leave, the arrow that goes up. If you press that,
yeah, that's that. Yeah,
that should stop the sharing.
No,
that's okay.
Doesn't seem to give me an option to do that.
That's okay. So I think we've got one question now. It's Glyn, if you would like to start us off.
Yes, I just wanted to clarify one thing that John said. You said that the NICE guidelines that I shared said there was no evidence for PBS. Now, NICE has a very particular view of evidence, so it only considers evidence to exist if there's been a randomised controlled trial, and at the time there hadn't been. Even Angela Aseotis' trial hadn't reported at the time. So what it did say was that ABA had sufficient evidence, and it found some systematic reviews of ABA done by a woman who I'm afraid her name escapes me, from the Netherlands. And so it said, yes, there is definitely evidence that ABA is effective, but no evidence that PBS is effective because there were no randomised controlled trials and there hadn't been any funded. So I think it isn't quite right to say that they said that there's no evidence for PBS, because ABA, after all, is what underlies PBS.
Well, Glyn, I think there's a lot in that. It did say there's no evidence for PBS because I put the actual quote up on the screen.
Yeah, but it was talking about randomised controlled trials, and there hadn't been any.
Yeah, well,
I mean, that is a fault of NICE. It drove me mad being on this NICE committee because of exactly that.
But with respect, you can't have your cake and eat it, because the reason we're running, the reason we're about to run a randomised controlled trial on sex offender treatment, and the reason we're and the rationale for selling that to commissioners and services that they should engage in that randomised controlled trial, despite the ethical issues, is that there actually is no strong evidence for sex offender treatment otherwise. There is evidence, but it doesn't add up, it doesn't reach the threshold in terms of RCT.
Yeah, and none of that research of mine ever got as far as a NICE guideline because there hadn't been any RCTs on it. But there is certainly in that challenging behaviour guideline statements about the effectiveness of ABA.
I agree, but again, I set it out really clearly in my commentary. People are welcome to go and have a look at that. That there's a live debate in the PBS community about whether PBS incorporates ABA or is a separate, a distinct approach. And there are many people in the PBS community, and I quote them, say that it's a unique, distinctive science that is different to ABA. It's whereas Gary Lavinia says ABA and PBS are the same thing.
Yeah, well, of course, they're not quite the same thing, but I don't think people would disagree that ABA underlies PBS. PBS has some additional things on top of it, particularly in relation to ethics and rights. But I'll shut up because there are lots of other questions, I'm sure.
Yeah, it has additional things, but it doesn't actually have all of ABA. It's asymmetrical. It has environmental adjustments which deal with the antecedent issues, but it actually definitely doesn't include skills training, and it very definitely doesn't include contingency management, which ABA does. So it's an asymmetrical intervention, which is why I think you're struggling to get evidence for it. That's an argument, a discussion we can carry on with. Yeah. I've been attending to the presentation, Vivi, and obviously talk and responding to Glyn. So I don't know if you want to sort of pick some. There might be themes in the questions or things that people.
I think we do have 4 people that we do have 4 more questions, and only 10 minutes left. So if we continue, I think, with the live discussions rather than and then we can have a look at the comments. Ian Penfold, you're next.
I must say, just to start with, I'm not an academic, so go gentle with me. I'm somebody who is an expert by experience with the NHS CTR programme and a local champion for the Challenging Behaviour Foundation. I have an adult son who has severe learning disability, epilepsy, autism, and severe and challenging behaviour. So, like many of you, I suppose, I've worn the bruises and learned my lessons from practical rather than theory. I want to make a comment about the Mental Health Act changes proposed, which I think are it's a dilemma, isn't it? I don't know how you feel about this. I'm worried about it being removed, because if it's removed, what do you do when somebody with challenging behaviour needs to be in a safe environment to protect them or those around them? So if we take it as you've shown on the presentation, if we take it out in the Mental Health Act, where on earth are those people going to go? In my area, many of the crisis houses have been closed by the councils to save money, and there aren't any options available. We have to focus on local needs and the funding to do that. Sadly, the money hasn't been forthcoming, and councils and the NHS have been squeezed so much that in a lot of ways we're trying to address the symptoms and not the cause of the problem. So that's the thing I wanted to say. And also PBS for me is, I think that's the answer. Without PBS, I think my son would be an inpatient. I think we need more research and more evidence. PBS is something that needs maintaining and developing, and more training for local staff. And until the government invests in this, I think we'll get nowhere. The CTR program itself is struggling because, as we've said, the patients are not being discharged. Too many are being admitted simply because of failures of funding and local services not being up to standard. Thank you.
Thanks. I agree with everything you said. I'm, as well as having an academic role, my day job is as a consultant psychologist in the NHS, but as a responsible clinician looking after detained patients, both in the community, on CTOs in the community and in inpatient settings. I've recently moved from learning disability services into our acute services, because the answer to your question is where people will end up is on acute admission wards with a misdiagnosis to get them in there. So people will be making things up about the diagnosis to get them off, get them safe, but they'll end up in services with staff who wouldn't know somebody with a learning disability if they fell over them and don't know what to do with them. So it'd be very unsafe. Or if the challenging behaviour looks more like offending behaviour, then they'll go down the criminal justice route and end up in jail.
Yes, and could I just say that there's a phrase for not offensive, aggressive behaviour, which sometimes is taken to mean, a bad thing, when actually we all know that it's a symptom of unmet need.
For some people, there are lots of people with mild and borderline intellectual disabilities where it's a symptom of delinquency and criminality, actually, but I think there's a range.
Thank you very much. If we move on to Tamsin Williams.
I can't get unmuted. Can you hear me?
Yes.
Hi. So I'm primarily a clinician, and I agree with you that it made for very unpalatable listening, particularly given today I spent the day training our nursing in our NHS area how to deliver and undertake PBS interventions. But what I can't help but wonder when listening to you is it that the evidence base isn't being gathered rather than it doesn't exist? Because I know that as a clinician, I'm inherently bad at, I suppose, gathering and reporting on the data. I do primarily work with people who would be more what the build groups are talking about, so would have moderate to severe learning disabilities and challenging behaviour. And certainly we do see anecdotal evidence that PBS works, but I just can't help but wonder, is it that we as clinicians are not reporting this when we should be? We're not writing it up, when we're not helping to gather that evidence.
Yeah, I think it's a really good point, Tamsin. I think I'm not saying that PBS can't be effective. I'm saying that thus far we've failed to demonstrate that it's effective in a systematic way through good service evaluation and research. I think, as I've mentioned to Glyn, I think there are reasons to doubt or reason to think that it might not be effective, because I think it tends to fall short of ABA. All of the elements of ABA, it's asymmetrical. I think when you look at Peter Baker, and I can't remember, sorry, apologies, can't remember who did the paper with, where they looked at the content of training courses for PBS around the country, it fell well short of enabling people to deliver effective interventions. But I think there is this issue of, if you're working with people with more moderate, even severe or profound levels of disability, or PBS, if it is ABA based, it's based on learning theory. And for opportunities to learn, you need to have lots of opportunities. So high frequency behaviours lend themselves to an ABA based PBS intervention, I would say. But often the people who are populating the particularly secure inpatient services are at the mild end, borderline intellectual disability. They're exhibiting low frequency, high impact behaviours. So there isn't the opportunity for learning through the learning theory underpinning ABA that you would get otherwise, which is why the more criminogenic focused interventions based on risk needs responsivity have demonstrated more powerful outcomes.
Thank you.
Thank you, Tamsin. Peter Baker has a question as well. Peter.
Oh lordy.
Hi, John. I think you've addressed it. I think you were being a bit cheeky in the 2 slides that you put up when you covered the sort of evidence base of PBS, and PBS is a complex psychosocial intervention, and the evidence base is equally sort of complex. And I think, in a way, you've addressed that. However, we need to be concerned. I'm concerned about the message that is there. I don't think you needed to do that in order to make the very well-intentioned and sound points that you made. But you knew I was going to say that anyway.
Well, Peter, I'd be very interested for you to either outside of this meeting, or do it now if you want, tell me the bits that I put up that weren't accurate. Because I did present this stuff at a Build presentation which you attended last year, and I think you agreed with my position on the evidence.
It's not about accuracy of what you put up, John, as you know. It's about completeness and it's about nuance. And I'm also aware of what the time is, and I think it's not the time and place. But as I said, I don't think it was worthy of you, John. It wasn't worthy of you.
Well, what I put on the screen today, I did very carefully in a considered way, Peter. So sorry about that. But as I say, the evangelists, the believers, don't like it. But that's tough. Get the evidence.
Okay. So I think that we have time for it's Adam and Clive, and then we're going to have to end it there. So Adam.
Thank you. Really interesting presentation, and there's some good papers for me to go and look at. This may take the form of more of a rhetorical question, and I think Ian articulated very well some of the things that I thought about this. I'm actually currently a doctoral student, but I did work for a local authority, which I won't mention, previously, and I had some contact with transforming care, going to meetings and familiar with the CTR process and so on. And one of the things anecdotally I heard was sometimes people are ready for discharge and people agree that they're ready for discharge, but because of the dearth of community services for them to be discharged into, they end up languishing. Now my background's more in social care than the NHS. I know local authorities do have commissioning responsibilities, which, if there aren't sufficient services, then surely there needs to be some kind of sanction or enforcement against the responsible commissioners. I don't know whether that's a bit of a strange take on this, but I can't think of what else can be done to address these commissioning gaps. And I just wondered if you had any thoughts about that.
Adam, you make a good point. I spend probably 50 to 60% of my clinical time, my time as a clinician, a responsible clinician, fighting commissioners and local authorities who have a statutory responsibility under Section 117 aftercare to provide support for people to leave hospital safely. And I ran a service where we managed to close the beds over a period of 3 years by getting good at discharge. But as that's transforming care. Since transforming care, it's actually become worse. So actually moving people out of hospital safely who don't need to be in hospital is more difficult than it was before. The white paper is proposing some statutory force around the issues that you're talking about, but whether that will actually result in it's all about resources. The white paper, if you look at it and read it carefully, it's all about resources and resource management. Little about, although it purports to be human rights based, it's actually about money. So we'll see. But it's a good point, well made. Thank you.
Thanks for the reply.
Thank you. So last question from Clive.
Hi, yes, thanks very much. It was really a comment about the earlier slide, which said that we don't fully understand the reasons for the failure of the Transforming Care programme. The comment I wanted to make was specifically about the way that funding flows. You talked about that those funding flows that seem to be drawn towards independent providers, and there's clearly a link there. You can join up the dots in terms of Walton Hall and Winterbourne View if you wanted to, because obviously Danshell was the organisation that purchased the Castlebeck company when Winterbourne View happened. So this was really about those funding flows. I wanted to make a particular comment about third sector organisations that behave in ways that are not very different from for-profit organisations as well, because it isn't just about the independent sector, in my opinion and my experience. And just really to make the point that there's an organisation called Red Quadrant doing some work on behalf of the Building the Right Support Delivery Board that's looking into the way funding flows are driving the wrong behaviours. And I guess I wanted to just sort of make sure everybody was aware of that, so that some of the data that you presented, John, can be fed into the Red Quadrant work. The concern I have about this is whether or not Red Quadrant will be bold enough in what they come out with, because to go back to the point about the failure of the Transforming Care programme, a lot of this, in my view, is about the application of markets where arguably they don't belong.
Yeah, I would agree. And the Lancaster University report, as it were, picked up on this a few years ago, the marketisation, commodification of these services. Interestingly, of course, in the 2015 plan, it was very clear that there would be an evaluation of transforming care. We've never seen that evaluation. So when we say we're not sure why it failed, well, we can make some guesses, but the evaluation was never. Well, I've never seen it. I did a presentation similar to this before Christmas elsewhere, and somebody on the call on the seminar said, in fact, there had been an evaluation. It had been completed, and the report has been written, but it hasn't been released. So that it's interesting to speculate why that would be.
I think been released.
It has been released. John. Yeah, it has.
Has it?
It came from Birmingham, not from people with particular expertise in learning disabilities. So not from people like John Rose, but from a health services department within Birmingham. I can send you the link. I haven't read it yet, but I have at least found it.
It doesn't address those marketisation.
No, it's very limited, issues. Basically.
Yeah, it doesn't really go far enough, and I don't think it explains the reason for the failure of the programme properly.
I quite agree with you, Clive.
Thanks, Clive. It's really helpful. Cheers. Thanks, Clive. Vivi, do we need to stop now? Yeah, I'm happy.
Yes, please.
I'm happy to keep going. I'm all right.
I think there's childcare and all kinds of issues coming in. So I'm afraid we'll need to stop here. Thank you so much.